Welcome. Thank you for choosing to join us for this online activity, Optimizing Solid Tumor Management with PARP Inhibition, Strategies for a Changing Paradigm. This activity is supported by independent educational grants from AstraZeneca and Merck, and presented by Creative Educational Concepts. To claim credit for this activity, be sure to complete the post-test questions and the evaluation.
Today's presentation is Optimizing Solid Tumor Management with PARP Inhibition. So now I'd like to turn this over to Dr. Pillier to talk about the state of the science with PARP inhibitors.
Well, thank you so much to Dr. Safji for the introduction, and thank you to the organizers for inviting me to be a speaker on this panel. So first off, just a 60,000-foot view on PARP inhibition as the poster child of this treatment paradigm known as synthetic lethality. As seen in the pictures here, with PARP, the main mechanism of action in terms of its anti-tumor efficacy is by way of PARP trapping. So it has anti-enzymatic activity, but via PARP trapping, binds to damaged DNA. And with a PARP inhibitor, that PARP is not allowed to be released, leading to replication fork collapse and insurmountable instability. With the synthetic lethal relationship seen specifically in cancer cells that are deficient in the faithful homologous recombination repair DNA pathway. These cells are specifically more reliant on error-prone DNA pathways, which PARP participates in, including non-homologous end joining repair and base excision repair. So homologous recombination repair is an essential and, again, most faithful DNA repair pathway. It is just one method of repairing breaks in DNA. And HRR proficient cancer cells or cells utilize sister chromatid to perform, again, high fidelity repair of DNA double-strand breaks, whereas HRR deficient must rely on alternative, more error-prone pathways, including NHEJ and others listed here. So with various PARP inhibitors seen here, there are different degrees of PARP trapping capacity. Where we have veliparib on the left, which has anti-PARP enzymatic activity, but has essentially no PARP trapping capacity, all the way over to the most potent PARP trapper on the right is talazoparib. But you can see that PARP trapping capacity also factors into the maximum tolerated dose, the toxicities, which we'll touch on later, and the dosing in the clinic. So again, a 60,000-foot overview of all the FDA-approved indications for PARP inhibitors. I won't read through necessarily each one here, but will make a note here, as this is just a recent development of the voluntary withdrawal of niraparib, olaparib, and rucaparib in the metastatic ovarian cancer 3+ line setting. And that was because subsequent data showed there was lack of survival benefit and actually increased risk of death in that patient population. Also want to highlight here the indications vary from disease site to disease site in terms of the biomarker selection, where we have in certain cancer types indications for germline BRCA mutations only, such as in breast, and in other tumor types, indications for both germline or somatic mutations, such as in prostate cancer, and then other indications, such as in ovarian cancer, that are agnostic to BRCA status. So again, here, just touching on the fact that this recent development of a withdrawal of these 3 PARP inhibitors in the metastatic 3+ line setting in ovarian cancer. So biomarker testing for PARP inhibition, how do we do this and when? And so the first graph showing on the left here is a study that was published just a few years back in Nature, showing the penetrance of BRCA gene mutations are not universal across all solid tumor types. And so BRCA as a tumor type agnostic biomarker likely does not hold weight because with tumor types, including ovarian cancer, pancreatic cancer, breast, and prostate being most penetrant. And this is showing also the germline to somatic ratio of these variants, where you can see there's quite a difference in, say, ovarian cancer, where the majority of mutations are coming from the germline, pancreatic cancer as well, whereas prostate is unique in that it sits about 50% germline, 50% somatic origin of BRCA mutations. Genetic testing comes in two forms. We have germline or hereditary testing, which is using blood or saliva, or in rare cases, hair or skin biopsy samples. And importantly for patients is that this type of variant can be passed on to subsequent generations and shared amongst family members. So it has much bigger implications than just for the patient and treatment selection. And so the other form of genetic testing, of course, somatic or cancer cell specific, and again, comes in multiple flavors where we have tumor biopsy testing or tissue-based, as well as now the rapid development of liquid-based somatic biopsies, including circulating tumor cells, cell-free, and circulating tumor DNA. And the choice between which somatic platform to use is dependent on the situation in front of you, meaning there's pluses and minuses to liquid-based biopsies versus tissue-based biopsies. But the situation of which to choose is dependent on that patient, where, say, for instance, in prostate cancer, many patients have bone-only metastatic disease. It's sometimes hard to isolate DNA for testing from bone metastases, and in that case might consider a liquid-based platform. So the potential results of the test that you're going to be talking through with a patient include a positive or actionable mutation in a cancer-related gene was found, negative, or what is commonly found as a variant of unknown significance, meaning there is a change, however, it has no known relationship to cancer development or no known actionability. In terms of testing for BRCA1 and 2 specifically, now as part of NCCN guidelines, prostate cancer, for instance, includes all men with metastatic, regional lymph node positive, or high-risk localized disease should be offered germline or hereditary testing at their first visit with the oncologist. And there are other criteria-free testing tumor types, including pancreatic cancer, ovarian cancer, and triple-negative breast cancer, as well as male breast cancer. In terms of somatic testing, this can be repeated, and the best time to obtain somatic testing is at tumor progression. And this somatic profile can evolve with treatment pressures. So focusing in on prostate cancer for a bit, DDR or DNA damage response gene mutations are found in upwards of 25% of metastatic prostate cancer. Again, it's a mixture of both germline and somatic origin mutations, with BRCA2 being the most frequently mutated gene, followed by ATM, CHEK2, and then other HRR repair genes. So going now into the clinical data for PARP inhibitors across various tumor types, first starting with prostate cancer. So this is the PROfound study, phase 3 study of olaparib single agent in metastatic castrate-resistant prostate cancer. Highlighting here, there are two cohorts. Cohort A included patients with BRCA1, BRCA2, or ATM gene mutations. Cohort B included patients with mutations in 12 other HRR or DDR genes. This study randomized between olaparib or physician's choice change in a second generation anti-androgen. So I want to take a minute here just to point out that we now know, subsequent from this study as well as other studies like CARD, that is a bit of a false comparison in that switch in androgen receptor signaling inhibitor has been inferior choice rather than switching to a different class of medicine. But in this study, the overall response rate seen in the cohort A, 33% in the olaparib arm, and led to a significant delay in pain progression. as well as the median overall survival in cohort A was 18.5 months versus 15 months in the AR switch arm. Important to highlight here in this study and other PARP inhibitors in prostate cancer is that the response is driven almost exclusively by patients with BRCA2 mutations or closely related genes such as PALB2, RAD51 complex genes. Subsequent analysis of other gene mutations, including ATM, have shown a lack of benefit with single agent PARP inhibition. However, these studies were not powered to do gene by gene subgroup analysis. So this again is just highlighting that the actual mutation matters, which gene. So this is from TOPARP-B. So this was the use of olaparib post-taxotere metastatic castrate-resistant prostate cancer. And again, highlighting in the different colors with red being BRCA, blue being ATM, that the response is driven largely by the BRCA mutant patients. Talazoparib in metastatic castrate-resistant prostate cancer, so TALAPRO-1 study. This was talazoparib after AR signaling inhibition and taxane, and the list of included genes there. Again, highlighting that the response is driven largely by patients with BRCA2 gene mutations, and the objective response rate seen in soft tissue disease as noted below. So after median follow-up of 16.4 months, the objective response rate was around 30%. On to rucaparib, the Triton-2 study. The independent radiology review and investigator assessment showed a 43.5% overall response rate. And here highlighting with the waterfall plot that germline and somatic origin mutations can display response to single agent PARP inhibition. And again, this is one area where prostate cancer sort of stands out amongst the others. So on to pancreatic cancer with the POLO trial. Primary endpoint was progression-free survival. This was patients who had received upfront platinum chemotherapy, and they were randomized to olaparib versus placebo. Again, want to highlight here the comparator arm of being placebo, not necessarily something that you would do in the clinic, but nonetheless, the olaparib arm showed a median progression-free survival of 7.4 months versus 3.8 months. It did not meet its primary endpoint and did not improve overall survival. But I do think it's important to note here on the curve on the right that there are a group of patients with a very aggressive disease who are having a benefit at the tail end of that curve. And so it highlights the point that even within patients with BRCA mutations, there is heterogeneity, and figuring out that heterogeneity will be important moving forward. So again, overall survival results just showing here that separation of the curve and the tail, that there are patients who are having longer duration benefit. So moving on in terms of ovarian cancer. So this is looking at the SOLO-1 trial and now has 7-year follow-up data and showing that olaparib demonstrated clinically meaningful improvement in overall survival. However, it did not technically meet the significance threshold, the p-value listed below. In terms of the progression-free survival, we see 67% versus 46.5%. And so this was in the maintenance setting in patients olaparib versus placebo in platinum-sensitive patients. Highlighting as well that throughout all these studies, platinum sensitivity in itself can be a biomarker for PARP selection. On to niraparib from the PRIMA study results. Again, PFS as a primary endpoint showed benefit to the maintenance niraparib consistent across patients. And importantly, this was regardless of the presence or absence of homologous recombination deficiency in platinum-sensitive patients. So on the left is the group with HRD, and on the right is the overall population. So on to some combo studies, and we'll pause here as we're going to be talking about ovarian cancer. However, this same concept is being applied across various tumor types. where by targeting a oncogenic pathway, including VEGF, PI3 kinase, and in prostate cancer, androgen receptor signaling, can induce, in the preclinical models, induce a HRD-like or BRCA-ness phenotype and induce sensitivity to PARP inhibitors. So this study combined olaparib and bevacizumab compared to bevacizumab maintenance alone in the PAOLA-1 study, and showed that in HRD positive non-BRCA mutant patients, so this is HRD positive by a genomic scoring system that incorporates various genomic features of HRD, including large-scale transitions among other markers, and found that the median PFS in the olaparib combo arm was 28.1 months, and in the versus 16.6 months. In BRCA mutant patients, that is improved even further with 37.2 months versus 21.7 months. And same combination, PARP inhibitor and bevacizumab in ovarian cancer with the OVARIER trial. So this is updated data from the phase 2 study. Patient populations around 50% were HRD positive, 63% had neoadjuvant treatment and debulking surgery. And the combination in the overall population seen in the plots on top and in the HRD specific population seen on the bottom. And so benefit is extended to the entire population, but as is consistent across all the PARP inhibitors as a class effect, is that the HRD population derives more benefit from the addition of a PARP inhibitor. And rucaparib in ovarian cancer. So this is monotherapy looking at first-line maintenance. It is pending FDA approval. However, again, as a class effect, demonstrated significant benefit of rucaparib versus placebo in the HRD populations, as well as the indeterminate variant status. So similar studies showing similar results with PARP inhibitors. Lastly, moving on to breast. So this is the Olympiad phase 3 trial looking at olaparib and metastatic BRCA mutant breast cancer. And seeing that the progression-free survival curve favors olaparib versus standard therapy with a hazard ratio of 0.58 is listed. And moving PARP inhibitors earlier in the treatment course, we have adjuvant olaparib in localized early breast cancer in the Olympia study. Again, comparing olaparib versus placebo and looking at invasive and metastatic disease-free survival. Both favored the olaparib arm in germline mutant BRCA1 or 2 patients. And at the bottom there, significant overall survival improvement at the second pre-specified analysis with the hazard ratios listed below. Lastly, talazoparib in advanced breast cancer, part of the EMBRACA trial, phase 3 study, randomized 2-to-1 talazoparib versus standard of care chemotherapy, looking at overall response rate and progression-free survival, both significantly better in the talazoparib arm, again, in germline BRCA1/2 mutant patients. On the right, hematologic grade 3/4 adverse events were seen in 55% of the patients who received talazoparib and 38% of the patients who received standard of care therapy. I think we're going to get more into the side effects and toxicities in later slides. So forest plots here showing that the talazoparib benefited across all of the subgroups, aside from previous platinum treatment, crossed across the line, but all the others significant for the subgroup analyses. All right, I will turn it over.
All right, thank you so much for inviting me here today, and thank you, Dr. Sabji, for the introduction. So next we will be talking about the role of PARP inhibitors in practice, and what does the NCCN guidelines say, how we use these agents and side effects, and how do we manage those side effects. So I wanted to orient everybody to the categories of NCCN recommendations and what these mean, to keep them in mind as we talk about the recommendations by the NCCN guidelines on how do we use these agents. So the table at the top includes the categories for recommendations, going from category 1 all the way to 3 with the level of evidence, and also the uniform consensus decline as we go down from 1 to 3. So category 1 is based on high level of evidence as well as uniform consensus, but category 3, it depends on any level of evidence, but there are major NCCN disagreements that the treatment is appropriate. And the same for categories of a preference. So this is very important to keep in mind that this takes into account not only the efficacy and the safety, but also the affordability of treatment. Okay, so we'll first talk about ovarian cancer, and this slide goes over the first-line maintenance therapy post the primary treatment with debulking surgery as well as a platinum-based chemotherapy. So criteria for using PARP inhibitors in the setting include stages 2 to 4 ovarian cancer, and patients must have had a response to primary treatment with surgery and a platinum-based chemotherapy. And with respect to the BRCA mutation status and HRD status, that depends based on the agent, and we'll talk about that in the next slide. However, I do want to point out that there's limited data to use of PARP inhibitors maintenance therapy in stage 2, and often treatment for that stage is extrapolated from trials that included patients with the stages of 3 and 4. Similarly, the patients with less common histologies such as a clear cell, as well as carcinosarcoma, these patients may benefit if they have germline BRCA mutation, but the level of evidence comes mostly from high-grade and grades 2 and 3 endometrioid carcinoma and high-grade serous carcinoma. So this slide goes over the current guideline recommendation for maintenance first-line therapy of PARP inhibitors after response. So the response to the previous treatment has to be either a complete response or partial response. Having a stable disease by itself is not sufficient to move on to using PARP inhibitors as maintenance therapy in this setting. So the recommendation depends largely on whether bevacizumab was incorporated in the initial treatment or not. So on the left, if no bevacizumab was part of the primary treatment and the patient has a BRCA wild type, then observation is an option, or niraparib can also be recommended. Everything that is not associated with a certain recommendation in the boxes, these are category 2A. If patients have germline or somatic BRCA mutation, then either olaparib or niraparib are both category 1 recommended agents in this setting. And if patients did receive bevacizumab in a prior lines of therapy, then treatment will also depend on whether they are BRCA wild type or not. So if patients are BRCA wild type, then patients may proceed with bevacizumab maintenance therapy. Keeping in mind that maintenance therapy, the data comes mostly from patients with the stages 3 and 4 ovarian cancer. Now, if patients have germline or somatic BRCA mutation, then it is recommended that you add olaparib to bevacizumab, and this is category 1 recommendation for patients with a BRCA mutation. If the patient has any other abnormality within the homologous recombination repair genes, or also known as HRD, then olaparib can be added to bevacizumab in this setting. Now, there is a recommendation to move on to treat the patient with monotherapy of PARP inhibitors as maintenance after first-line therapy without the bevacizumab. And this is because of the magnitude of benefit was seen in patients who have a BRCA mutation specifically. And then with that acknowledging that we really don't know what the specific efficacy or safety of those agents after treatment with bevacizumab, as the studies that Dr. Pillay went over included patients who did not receive bevacizumab in the first-line setting. However, given the benefit of these agents, NCCN recommendations do allow for monotherapy with either olaparib or niraparib and not continuing with maintenance bevacizumab if we need to. Okay, so I am sorry, I have a hard time seeing the slides, so I'll move around. Okay, so then this table here, we just summarizing the treatment with PARP inhibitors in ovarian cancer specifically. So we talked extensively about the first-line maintenance therapy. We have olaparib and niraparib as approved agent. Rucaparib is not yet FDA approved in that setting. But when we talk about reusing these agents as maintenance therapy after recurrent treatment, patients also have to be have responded to prior platinum therapy. So they must have a platinum sensitive disease still, and they must have either complete or partial response to that treatment. And they can be treated with either of the three agents in this table, and regardless of the BRCA or HRD status in this setting. I do want to highlight that recently we did have updates from the LV16/NOVA clinical trial that looked at maintenance niraparib and post-recurrent treatment. There was seen overall survival detriment in terms of the hazard ratio going above than 1 in patients who did not have germline BRCA mutation. So the ASCO guidelines actually published a new updates to their recommendation more recently, warranting cautious when trying to use niraparib as maintenance treatment post-recurrent therapy in patients who do not have germline BRCA mutation. Even in the group that did have HRD positive tumors, these patients did show detriment in overall survival. So that must be weighed against the benefits seen with a progression-free survival in that setting. All right, so for breast cancer, we have two agents that are approved in this setting, with olaparib being the only one approved in the adjuvant treatment, in addition to the metastatic setting. Across all indications of PARP inhibitor in breast cancer, patients must have germline BRCA mutation and not somatic, not HRD, but patients must have germline BRCA mutations. So in the adjuvant setting, patients also have to have high risk features defined in the table below. In summary, if patients receive neoadjuvant chemotherapy, they must have had not achieved a complete pathological response. So they have to have a residual disease. Or if patients received adjuvanted treatment, then they have to have lymph node involvement, with the number of required lymph node involvement varies based on hormone receptor status. So in this population and in all populations of a breast cancer patient, keep in mind that all of these patients are HER2 negative patients. And also adjuvant olaparib can be combined with adjuvant endocrine therapy in this setting, but it cannot be combined with adjuvant radiation if needed, because it is known to be a radiosensitizer agent. And here is a summary of PARP inhibitor use in breast cancer. One thing to add is that we know that olaparib is approved as adjuvant and also for the metastatic setting. Rucaparib, talazoparib is the other agent that's approved in metastatic breast cancer. That is hormone receptor either positive or negative, but the patient have to have a HER2 negative disease and have to have germline BRCA mutation. The NCCN does not differentiate between these two agents in the metastatic setting, but they do extend the recommendation to include patients regardless of HER2 status. The FDA approval is for HER2 negative only disease. Okay, so for prostate cancer, I will not go into the details here as Dr. Pilier went over a lot of the studies that highlighted the use of these agents. But to summarize that these two agents that we have available for prostate cancer, we have olaparib and rucaparib. They must be used with androgen deprivation therapy. The difference between the two agents is that olaparib can be used regardless of a prior taxane therapy. Rucaparib patients must have progressed on not only novel anti-androgen therapy, but also on a prior taxane therapy. And then there are differences in terms of the BRCA status and also the HRD status between the two agents. For pancreatic cancer, the approved agents currently, so the NCCN do recommend either olaparib or rucaparib with different category, but olaparib is the only FDA-approved agent in this setting. Both of these agents can be used if patients have received 4 to 6 months of first-line platinum-based chemotherapy with no evidence of a progression. And patients can then be switched to maintenance therapy to either the olaparib, which what we have the most evidence in, or rucaparib, especially in patients who are deemed unfit to receive chemotherapy. The NCCN do allow for use of this agent if no prior taxane was used in that situation. Okay, now moving on to talking about the toxicities and how we manage toxicities with PARP inhibitors. One of the most common side effects of PARP inhibitors is actually fatigue, and this can impact the quality of life, especially in young patients who have families to take care of and then have full-time jobs. So it is very important that we monitor for anemia because this is a known adverse event of PARP inhibitors as well. And we need to monitor for any residual anemia from prior chemotherapy prior to starting the PARP inhibitor as well. Other recommendation is to screen for and rule out other causes of fatigue, such as hypothyroidism, poor nutrition status, depression, uncontrolled pain. And then exercise is recommended by a lot of guidelines. There are a lot of studies that show the benefit of exercise. However, we do want to make sure that we address any limitations, any physical limitations to exercise by referring patients to physical medicine to provide further assessment. And also dose modification, dose reduction and interruption is very necessary, especially for fatigue that is not responding to other non-pharmacological agent interventions. So in a clinic, what we often do, we do dose titration over a few days until we reach the full dose that the patient can tolerate. And then prescription stimulant agents is always an option as well. Nausea and vomiting, this is another side effect that is common with PARP inhibitor that can also impact the quality of life. Even if grade 1 nausea and vomiting can significantly impact patients' quality of life. So this is something important that we need to educate our patients on, be proactive about with PARP inhibitors. So we have olaparib, rucaparib, and niraparib are associated with high to moderate emetic risk. Talazoparib, on the other hand, has the least GI side effects and is associated with low emetic risk. What we do in a practice, we send patients prescriptions for antiemetics prior to initiation of therapy, counsel patients on a proper use, and we are very quick to initiate a prophylaxis treatment with anti-nausea medications by scheduling those medications prior to each dose when patients develop nausea. And then usually the nausea resolves within the first 4 to 8 weeks of therapy, but it's important to note that it may be necessary to hold and reduce the dose if patients have weight loss of more than 5%, have significant fatigue that is not improving regardless of pharmacotherapy interventions, and also is associated with poor performance status or vomiting. Hematological toxicity, there is a lot of variation in terms of the grades and the severity of those side effects and what lineage is actually affected with each agent. So anemia, again, this can be seen across all PARP inhibitor agents. I do want to mention that in a clinical trials, management of anemia was very aggressive and may not reflect what we do in a practice. But regardless, if patients have symptoms, then blood transfusion can be used to support patients. And it's really known in a practice, while there are no clinical trials necessarily out there to back this up, but it is very well known in a practice that if patients develop anemia and then you interrupt the treatment, then you reintroduce the patient at the same dose, this anemia will recur. So sometimes we do have to do dose reductions. Unfortunately, what we do in a clinic, we provide blood transfusion support, especially if patients are symptomatic. And if the anemia persists and it requires more frequent blood transfusion, that's when we change the dose and reduce the dose, specifically for olaparib from my experience with that agent, but for talazoparib, because it is associated with a lot of high-grade anemia, we actually do reduce the dose at the first sign of anemia for hemoglobin less than 8. Thrombocytopenia, this is a side effect that's most commonly occurring with niraparib. In a retrospective study of the OV16 and NOVA phase 3 trial, higher proportions of patients who had low weight did have higher grades of a thrombocytopenia, and having a platelets at baseline of less than 150 and a low weight of less than 77 kilo were two significant factors predicting needing to dose adjust niraparib early on in a treatment. Thus, we adjust the starting dose of niraparib based on these two parameters, the weight and baseline platelets. But regardless, for thrombocytopenia, for neutropenia, or for any other cytopenia, it is very important to keep in mind that we do need to monitor those very closely, especially if there are cytopenias. We need to monitor at least weekly. And the reason for that is we want to make sure we are ruling out myelodysplastic syndrome and AML as well. The incidence is low, but it is reported, it does happen in a practice. The onset varies from 0.5 months all the way to 10 years. However, the median is about 9.8 months. And the latency from the initial dose of PARP inhibitors to development of the secondary hematological malignancy is about 17 months. It's very short compared to what we see with chemotherapy-induced leukemias, such as with alkylating agents, about 5 years, and also with a platinum therapy, about 3 to 4 years. So again, we need to monitor the CBC with differentials at least weekly until recovery. If the duration of interruption is about 4 weeks or longer and still those cytopenias have not recovered, then we do need to further investigate this and include our hematology colleagues to look into this. And if patients develop MDS and AML, the PARP inhibitor must be discontinued. Now, agent-specific toxicities, a lot of these toxicities, the top two are related to niraparib. We have hypertension. This is reported with niraparib at a median onset of 15 to 77 days. It is important to counsel patients that they need to monitor their blood pressure at home. The recommendation is at least once weekly for the first 2 months, and then moving on to doing less frequent monitoring. And of course, patients who have comorbidities related to cardiovascular disease, we want to monitor even more closely in this scenario. In a practice, what I do follow patients who are on oral treatment. So for niraparib, I have the patients measure their blood pressure, keep a log of this, and then they know when to contact a clinic immediately for which parameters. And then on a weekly interval, they provide those numbers for me to make sure that we are intervening if needed to. And then we have the other rare side effect is the posterior reversal encephalopathy syndrome. We counsel on any changes in headache or mental status changes, any vision changes as well. Pneumonitis, this is something very rare. It's only reported with olaparib, monitoring for a new or worsening dry cough with or without fever, any chest pain, any shortness of breath. If that is reported by patients, we get imaging, starting with chest X-ray to rule this out among many other causes that can cause pneumonitis, including infections. Now, moving on to talk about those specific nuances for each agent. So we have niraparib, as I mentioned, the dose needs to be adjusted based on patient's weight and baseline platelets numbers as well. The monitoring, as I alluded to, we do the CBC, CMP, as well as blood pressure. For specific characteristics to niraparib, as I mentioned, it's associated with a lot of hematological toxicity, specifically thrombocytopenia and hypertension. Olaparib, this is the oldest and first PARP inhibitor. I have to say that we have a lot of experience with this drug. We may be even more comfortable using this medication. But still, there are certain toxicities that we need to be on the lookout for. As I mentioned, we have pneumonitis, increase in serum creatinine, and this is related to inhibition of the transporters and not necessarily related to changes in the glomerular filtration. So it's not true renal function decline, but we do need to rule that out. Rucaparib, the difference here in terms of side effects compared to other agents, it is associated with increase in LFTs, so we need to monitor liver function enzymes, as well as rash and photosensitivity, and then the increase in serum creatinine, very similar in terms of the mechanism of that by inhibition of the transporters. Talazoparib, this is the most potent PARP inhibitor we have. If you look at the doses and how that's different from other agents, it does tell you that the potency of this agent. Now, specific side effects with the talazoparib that are not seen with other PARP inhibitors include alopecia. The good news, this is a grade 1. It's only hair thinning. It's not complete hair loss. I do have a lot of patients complain about that, and they actually do not like this side effect. And here is a summary of these agents. A few things to mention here is that renal dose adjustment is recommended and actually required for olaparib and talazoparib. Hepatic dose adjustment is only required for niraparib. All of these agents, except for talazoparib, are primarily hepatically and extensively hepatically metabolized. Drug interactions based on how they affect those enzymes, what kind of substrates they are, but there are a lot of drug interactions, especially with all these three agents except for talazoparib. And then I think the last portion that I don't see in the table here, but it is basically about what we talked about. Rucaparib, olaparib can inhibit the organic cation transporter and meta transporters, leading to increase in serum creatinine without changing the glomerular filtration. And with that, I invite Dr. Saji back to this stage to speak about adherence and financial toxicity. Thank you.
Thank you. And we'll kind of begin to wind this down. Talking about some of the things we have to talk about from a managed care perspective. So these drugs are all oral. So one of the big issues we're dealing with from the pharmacy perspective is adherence. I keep reminding our pharmacy residents that the most expensive drug in the world is the one that doesn't work. And if patients don't take them, they're not going to work. And so we need to make sure patients are adherent. What we do know is about a quarter of patients are suboptimally taking their medications. And this correlates with patient age, marital status, and other levels of depression, et cetera. So again, having some mechanism to follow up with a patient to determine, are they taking their medications? Are they taking them as they're defined? And get them to explain is very important. We've actually seen a few cases where we thought the patient was taking it, and because of financial toxicity, we're going to talk about, they never got their meds and never started them. And so again, it's one of those things that it's something that's very, very important to look at. We do individualized care, as Dr. Rahim actually talked about. We're looking at dose reductions, we're looking at the best dose, and our goal is to always balance safety and efficacy. And we remind the patient that it's not always one size fits all, and that we have to adjust things based upon, toxicity. Their schedules may change, and then again, we have to go back to the adherence process to make sure. And so we're starting to look at how do we do these kind of things. There's some innovative work out there looking at telephonic follow-ups, text messages, all of those kind of things are things that will ultimately help us track patients and what they're doing. I've even seen a presentation of a tablet that has a built-in microchip that's acid activated that sends a message to a smartphone app that tells you the patient took their pills. And so those kind of things are in our future at some point in time. Financial toxicity is a real thing. And this is a term that didn't even exist 10 years ago, or maybe 15 years ago. But it is something that we're starting to see more and more. The financial burdens to cancer patients are real. And often they're predictable, but a lot of times we're not really paying attention to what they're doing and we're really not asking. And so we need to think about what is the cost of the drugs and how does this fit into the overall care of patients. And so as we start looking at patients and start trying to identify who those patients are, what we know is that patients who have cancer have almost a 3 times higher likelihood of bankruptcy than those patients who don't. In a Kaiser Family Foundation LA Times survey, 20% of patients with cancer had been contacted by a collection agency due to medical debt, and 9% of those patients were filing for bankruptcy. If you do not know, medical debt is the leading cause of bankruptcy in the United States, and it continues to be the leading cause. So who are those people that we're looking for? Well, it turns out younger patients are at a higher risk than older patients. This is one of the few times where Medicare is actually good, because Medicare serves as a safety net, whereas a lot of younger patients don't have that safety net process, and they have higher out-of-pockets, high deductible plans are actually contributing to this, et cetera. Female patients tend to be at a higher risk than male patients. Non-white patients tend to be at a higher risk. And then the last group is the patients who have no social support. So when we look at the PARP inhibitors, then we need to start thinking about, from a financial perspective, what are we looking at? And so the cost effectiveness data from the PARP inhibitors is displayed in this graph. And what we have here is looking at all of the PARP inhibitors on the graph by disease state. And those in the blue were shown not to be cost effective. And those in the green are shown to be, or in the lighter green are shown to be cost effective. Those in the darker green are considered to be mixed. So you can see here, it's a pretty mixed bag. In the recurrent ovarian cancer space, two out of 13 studies have been shown to be cost effective. In ovarian and advanced ovarian cancer, 4 out of 6, 1 in prostate cancer. It's a 50-50 split in pancreatic at this time, and no breast cancer study at this point in time is shown to be cost effective. And again, we're talking cost effectiveness based upon different levels of threshold that's defined by the study. And so one of the things that we are finding is that if we treat all comers in the disease versus those that are biomarker driven, we're starting to see that there is cost effectiveness in a lot of cases. And again, on olaparib, the incremental cost effectiveness ratio was just over 105,000 per quality adjusted life year in patients with the germline BRCA mutations. In niraparib, in advanced ovarian cancer, it was not cost effective. And then in the new advanced ovarian cancers, again, neither one of those were advanced. But we do believe that the biomarker driving is probably going to be something that we're going to have to look at, because that tends to lend towards cost effectiveness. When you start breaking these down by drug, we can show that there are multiple studies in ovarian cancer for olaparib, and 2 of them were considered cost effectiveness. In the range of incremental cost effective, the ICER range was between a little over 66,000. And then there are some studies that were not cost effective that go all the way up to $600,000 per progression-free life year saved. In the recurrent, it was considered cost effective. In ovarian compared to observation, and new ovarian compared to observation, 4 studies, 3 were cost effective. Breast cancer, 2 studies, none were cost effective, but we're at a quality level that might be controversial. At 131,000, some people would say in cancer, that's cost effective. We've seen ranges from 75 to 150. And so again, it's kind of taken with a grain of salt. In pancreatic, again, compared to placebo, it's a 50-50 split. There is a study out there looking at a budget impact analysis in pancreatic cancer that says if we gave everybody pancreatic cancer that qualifies, what would it do? And it would basically bankrupt us. And so again, it's probably going to have to be biomarker driven at some sort in time. And then the prostate data is fairly new. There's 1 study at 116,000 per quality adjusted life year. The other drugs have less. Again, it's probably based on the fact they've been out less. And again, it's mixed results. In niraparib and recurrent, again, it's about a 50-50 split. But notice that the high range is $1.9 million per quality adjusted life year, which no one would ever consider cost effective. And the same thing in the new ovarian cancer. Yet there are studies that show that it's less than 100,000. So I think what we're going to need from all of this is more data to suggest whether cost effectiveness is actually part of the equation as we're using these drugs. So from a cost effectiveness perspective, we know that biomarker decision seems to be more effective than treating all. Cost effectiveness is affected by moving therapies earlier and then by extending overall outcomes. So we might see this change over time as we lengthen those outcomes. And we've seen this in the ICER analysis a few times where the first time they do the analysis, it's not cost effective. They go back at a later time and you've got a longer follow-up, and now that outcomes is driving it. So the outcomes is going to be very important. When you look at this, the sensitivity analysis, the main driver of 17 of the 20 studies was the cost of the drug. And what we're really going to have to do is, if the cost of the drug isn't going to come down, which I don't see that happening anytime soon, then the outcomes have to improve to reach more cost effectiveness. And so then the question I've started asking is, when do we start treating PARP inhibitors as a class? And just like we've done ACE inhibitors in the past, just like we've done beta blockers, proton pump inhibitors, you name it, when do PARP inhibitors start falling into this category? And then we start choosing them not based upon their indication, but what drug we feel is best for that patient at the time, and can we get to the point where I can say in my institution, this is our preferred product, and we're going to treat everybody that needs a PARP inhibitor with that preferred product. I don't think we're there yet. I think it's going to be a long time before we get there. My guess is we'll get there when the generic drugs start coming out, as these drugs start losing their patents. It's my personal opinion. And one of the things we know that's affecting financial toxicity is the cancer health disparities. And the social determinants of health are a big impact on financial toxicities and other aspects. And again, this is the definition of the social determinants of health that was published a few years back. So we do know that the PARP inhibition clinical trials, that there is a low participation of women in color. This study reviewed 15 phase 2 to 3 studies looking at PARP inhibitors for gynecological cancers. And they looked at it from what's called an enrollment fraction. So an enrollment fraction is looking at the number of patients enrolled as compared to the incidence of disease in that particular cohort, whether it's a racial or ethnic cohort. And non-Hispanic Blacks, Hispanics had the lowest enrollment as compared to non-Hispanic whites and Asian and Pacific Islanders. And so again, what the results of this were suggesting is that we need to open up clinical trials more to all ethnicities and all racial categories. And this is something that I know the NCI, ASCO, everybody's trying to do. How do we improve access to care? How do we improve access to clinical trials across all groups so that we have that diverse group, we have that equity available for patients? And so as we're talking about how do we make things better for patients, we need to make sure that all patients are receiving the appropriate education, and that shared decision-making now becomes a better important component, particularly as you start talking about cancer plans. When you talk to patients about what's keeping them out and access, a lot of it is trust issues, and shared decision-making goes a long way to helping with trust. And then access to a multidisciplinary team. You know, one of the philosophies at Mayo Clinic is two minds are better than one. So again, having more people there that can address the different aspects and having that specialized person that can address the transportation or the cost of care or the physician working on the diagnosis and the follow-ups and all these other things, it really begins to lend an access to care and improve the overall patients getting their care. So as we go, communication is going to be important, improving all of the communications between patients. This says provider-patient is probably going to be all disciplines and patients, and acknowledging the patient's belief in making sure that we don't have our own implicit biases involved, and that we increase the representation of minority groups in providers, so the providers can talk to similar minority populations, also in clinical trials, so we can explain to the patient that's sitting up front of us what is happening to similar people who look like them in the clinical trials. Cost is a big deal. We have to decrease the cost of care in some way. You know, copay assistance, patient assistance, that goes a long way. I'm very interested to see what the new Medicare rules of capping out of pocket at $2,000 is going to look like per year and how that affects things. And then little things like, how do we get patients to the facility? You know, if you work at MD Anderson or the two Mayo clinics, we have patients coming from hours away, driving 5, 6, 7 hours. And if you end up not being efficient and they have to spend an extra night in the hotel, that's a lot of money for patients out of their pockets. It's some of the things we need to do. And ultimately, and this is a challenge I would throw out to our pharma colleagues, we need to do outcomes research data to show that we're actually producing the outcomes that we want to do. Do that real world data so that we can see what we're doing and is it actually producing the results. So now that we've kind of laid the foundation, let's look at some real world applications and do some case presentations and some case discussions. We would encourage your feedback and presentation. We've also got question cards. So if you have any questions, please fill them out. We'll have people walking around collecting those. So our first patient is an ovarian cancer patient. She's 58 years old. She has newly diagnosed disease, stage 3, serous ovarian cancer. She has a CR to first-line debulking and carboplatin and paclitaxel and bevacizumab for 6 cycles. Her treatment was complicated by hypertension, and it was controlled by medications, but she also had myelosuppression, fatigue, and nausea. Her tumor testing has revealed a somatic BRCA2 mutation. The patient lives in a rural community with the closest cancer center more than 100 miles away. It's actually fairly common to what we see. And she's planning to return to work as soon as she can. She has health insurance coverage and needs to financially support her family. So, our experts, what's the best evidence based on the NCCN guidelines? Dr. Rahim, what do you think?
test the mic. Does that work? Yes, you guys can hear me. So we will talk about the best evidence-based and NCCN guideline recommendation, but that may not necessarily be the best approach for the patient. So we'll just summarize that up first. So according to the patient's stage, she's a stage 3 high-grade serous ovarian cancer. She did have a complete response to the first-line surgery and a platinum-based chemotherapy, and her treatment did include bevacizumab. And she does have BRCA mutation. So according to the NCCN guidelines and the evidence, her first-line therapy would be to add olaparib, maintenance olaparib to maintenance bevacizumab, continue to the olaparib for up to 2 years and the bevacizumab for up to 15 cycles, or 15 months of therapy. So that would be the best recommendation.
Okay, you agree, Dr. Paul?
Yes, yeah, based on the NCCN guidelines, that would be the best recommendation. The one additional comment I would add in terms of just a genetic testing thing that comes to mind is any patient with a somatic variant identified in BRCA2, if she hasn't yet had germline genetic testing, should do so.
And so what are we going to monitor for?
Of course. Now, before we talk about the monitoring, I do want to mention that the best treatment approach for this patient, as to, considering all the factors that she has, such as, like uncontrolled hypertension, as well as her ability to come to treatment to receive the intravenous chemotherapy or the bevacizumab portion of her treatment. And based on what we know about the magnitude of the benefit with monotherapy PARP inhibitors as first-line maintenance therapy, we may be able to offer this patient olaparib only and not continue the maintenance bevacizumab. So that is an acceptable approach. So what are we going to monitor for if, let's say, the patient is to go on maintenance olaparib only? We are going to monitor for CBC, and we are going to do this at baseline, as well as monthly prior to each treatment. And then in terms of side effects, we are closely going to monitor the patient for nausea, vomiting, signs and symptoms of anemia, so we can catch that prior to the patient's scheduled CBC appointment. And we do that, I'd like to share my experience, but we do weekly monitoring through the phone or through the patient portal messaging system that we have at Mayo Clinic with the pharmacist who's covering the clinic, and we do that at least weekly for the first month. And even more often if the patient does have symptoms that require urgent intervention.
So let's move on to the breast cancer patient. We've got a 35-year-old Hispanic female with stage 3 breast cancer, status post-neoadjuvant, pembro and carbo and paclitaxel, followed by doxorubicin and cyclophosphamide. Then she underwent a bilateral mastectomy. She tolerated all the treatments well and is looking forward to her hair growing back. The surgical pathology showed residual disease, and the genetic testing showed a germline BRCA1 mutation. The patient's primary language is Spanish. She works full-time and has a commercial insurance with prescription coverage through her employer. So given the aggressive nature of triple-negative breast cancer subtype and the residual disease despite first-line neoadjuvant, what's the best adjuvant treatment for this patient? Do we continue pembro, do something else? What do you think?
This case commonly actually occurs in real life of practice in terms of having to make a choice and select a treatment and also sequence therapy. There are a lot of questions than answers, the more clinical trials we have available. So for this patient specifically, prior to, let's say this patient does not have germline and BRCA mutation, then what has been done in practice is that, well, the number one thing to assess is the patient did not achieve complete response after neoadjuvant therapy and surgery. So we must then treat with either adjuvant capecitabine, but also the patient did receive pembrolizumab as part of her initial treatment, and continuing adjuvant pembrolizumab is very beneficial, especially in patients who have not achieved complete response. So then we run into this issue of, okay, what do we do here? Do we continue the pembrolizumab? And do we add adjuvant capecitabine? Per the CREATE-Exit trial, adjuvant capecitabine improves survival in this patient population. But then this patient does have germline and BRCA mutation and would benefit and qualifies for adjuvant olaparib for up to 1 year. So what do we do in this case? I would like to share our experience and what we do in a practice. And then there is no correct answer. There is no data currently to back any of those recommendations, but we would, in this case, continue pembrolizumab, and we will add olaparib, adjuvant olaparib for up to a year in combination with pembrolizumab in this patient specifically. And this is extrapolated from the Olympiad. So the Olympiad trial looked at olaparib in the metastatic setting for breast cancer, and olaparib outperformed capecitabine in that setting. So we are extrapolating information from the metastatic setting in patients with germline BRCA mutation breast cancer. So that's what we are favoring. We are favoring olaparib over capecitabine, and we are combining this with pembrolizumab. So we have to be very careful about added toxicities, whether we are combining the capecitabine with pembro or olaparib with pembro. There are a lot of added toxicities, specifically fatigue, as this can be seen with immunotherapy and is also seen with PARP inhibitors.
Dr. Pillier, this is a question that came in from the audience, and it kind of made me think about this as we talked about the germline testing. So the question is as we start developing artificial intelligence and machine learning, do you believe we're going to get to a point where we can have a better predictive algorithm on who should get it, which cohort should get PARP inhibitors versus just the way we're doing it now?
Yeah, so certainly it gets back to that, there's heterogeneity even within these biomarker subgroups. And certainly with these being relatively rare events in terms of these mutations, we definitely need to rely on bigger data and artificial intelligence and kind of crowdsourcing of this information to get a better understanding of what's driving that heterogeneity in response, to know, which patient is likely to have a longer benefit. And same goes not just for PARP, but for immune checkpoint. In this case, where we know that the combination of PARP and pembrolizumab is safe, been looked at across multiple studies, but unfortunately, despite very encouraging preclinical evidence, those studies have been negative for the overall populations. But there are rare subgroups who are deriving very durable benefit. So utilizing all we can big data wise to figure out that heterogeneity for sure.
So let's move to a prostate cancer patient. We have a 57-year-old Hispanic male diagnosed with metastatic adenocarcinoma about 3 years ago. He does have a family history in which his mother had ovarian cancer, maternal aunt had breast cancer, 2 brothers are healthy, children are healthy. He doesn't speak English, and he is dependent upon his children to help translate. And he's been on abiraterone acetate as ADT for 3 years. He now has a rising PSA on 2 consecutive readings. His testosterone level is at castrate level, and we are starting to see bone mets on PET scanning. He's had both somatic and germline testing, and germline variant was discovered in BRCA2. He does have good performance status and a normal blood count. So again, Dr. Pillier, I'm going to come back to you. What would you do next? Where you go next with this guy?
Yeah, so this is a interesting question. In prostate cancer, we're at a luxury where we have multiple now approved agents in this setting in the castrate-resistant space, ranging from Taxotere to olaparib for HR mutant patients, to PSMA lutetium following Taxotere, et cetera. So the sequence actually hasn't yet been worked out. But in terms of a patient with a identified BRCA mutation who has not yet received Taxotere, olaparib is the choice in terms of PARP inhibition for this gentleman.
And this patient and the one previous both are non-English speakers, so it's going to be very paramount as we start talking about making sure they understand the treatment, the education of the patient, that they're Now, the best thing is to do is to educate them in the language that is their natural language. And most of us now have translating services of some sort. You know, most of the institutions have native Spanish speakers now that do this type of work. And the follow-up has to be that way as well. And providing written information in Spanish. I know down in MD Anderson, I'm sure you deal with that all the time, right?
Oh, yes, and so important too for the genetic testing piece. There's study after study that shows non-English speaking patients are not being offered genetic testing because it does require that conversation and consent and sort of interpretation of the results and how it impacts not just the patient, but potentially their family members. And so having that conversation in the patient's native language is imperative so that they understand what they're consenting to.
It's amazing just speaking to someone in their language sometimes how much more you get, how much better you can to do this. So now we have a pancreatic cancer patient, 73-year-old Black female, obese, diagnosed with metastatic pancreatic cancer. She's actually in good performance status, ECOG of 1, has a family history of breast cancer from a sister, death from heart disease from her father at an early age, unknown family history on a paternal side, and mother is healthy with no known cancers. She does have germline testing showing deleterious BRCA2 variant and is started on first-line chemotherapy, which she tolerates well, overall with some residual anemia. Subsequently, she is started on olaparib per the POLO trial. 6 months into therapy, she has no progression of disease, but has recently required a transfusion for no bleeding and the olaparib dose with no bleeding. And their olaparib dose has to be reduced. So she's having trouble traveling to her appointments and does not have a large support system. You know, what strategies do we need to do to make sure she receives the optimal care? And this is where we got to start pulling in all of our social supports, all of our transportation help, all of the pharmacy helps, et cetera. More and more specialty pharmacies now will mail. We've got video visits. I'm going to ask both of our speakers to talk about their experience with video visits. And a lot of these kind of things then begin to help us expand what we can do to these patients. So Dr. Rahim, do you do video visits, and how successful have they been with you with adherence?
So we have video visits. The option is available to all of our patients. And then this is something that our providers do also in a clinic. For pharmacy specifically, so we offer not only video visits, but also phone visits. And we typically ask the patient, what do you prefer? What is easier for you? Is it okay that we discuss this over the phone? Would you like to set up a meeting in person? If you have an appointment, I usually schedule my patients to come and see me if they do have an appointment and if they have a busy day already in a clinic. But then we do offer this, and it is available. I have to say, however, we are in the process. We are working with the legal team. We are working with our, like technology people and everyone, trying to pull all the resources, because we have to make sure that we are following the rules, because now the public health emergency that is being not terminated, but more like coming to an end. So we have to make sure that we are meeting all the requirements when we do that legally, but it is available. We do use the portal system. Our patients love that. They are really way more tech savvy than I am. I do struggle with technology, and then they are great. It's very easy. I get blood pressure numbers. I send their blood work orders, and also we exchange a lot of information, pictures. We do a lot of pictures. So that's something that we would like to take care of when we implement the video visit fully for pharmacists in the oncology clinic. We do get a lot of pictures to assess skin toxicity with certain treatments.
So what about Anderson? What are you guys doing at MD Anderson?
Yeah, absolutely. I mean, everywhere, I think since the pandemic, video and telephone-based appointments have sort of exploded, and particularly with prostate cancer, with so many patients on oral agents and oral anti-androgens and PARP inhibitors, that the patients, deeply appreciate not having to drive back and forth, spend gas money, parking, et cetera, just to come in for toxicity checks. I will say, Every provider is a little different, but that first appointment with the patient, very much prefer to be in person to sort of establish that connection and trust that then, on follow-up appointments can be carried forward virtually. And we also now have moved our genetic counseling pretty much exclusively virtual.
Yeah, if you've ever parked in the medical center in Texas, you know it's not a fun thing to do. So
It's pricey too.
So the second question on here, I'll ask you, Dr. Pillai, how do we get more patients of color into clinical trials?
Yeah, absolutely. I think it's going to them. It's engaging the community to understand, what the deficits are, so that we can engage more, design the studies in a way that incorporates members of those community. For example, prostate cancer studies, again, going back to genetics, all the studies that looked at hereditary germline mutations were woefully underrepresented for African-American men who are more likely to have aggressive prostate cancer and die from prostate cancer. And so part of the strategies have been to go to communities and hospital systems that serve underserved populations and engage them more in everything from research to trial design to improve efficacy for treatments and access.
Dr. Rahim, we have another question here that came in. So for olaparib, you mentioned that up to 2 years worth of treatment with bevacizumab. So what do we do when that time's up? Do we just stop? Do we wait till it recurs? What do we do?
So a lot of studies actually, and even it's mentioned in the guidelines that if patients, like you do restage and scans, right? And then the patients is up to the 2 years of a treatment of olaparib. If the patients have partial response, so anything less than a complete response, you have the option to continue the therapy. And of course, that's a decision that the patient has to be part of as well. But a lot of times this is an option that we actually offer to the patient, that it's okay to continue beyond the 2 years if the patient has less of a complete response.
So that brings us to the end of our talk. Thank you for attending. We appreciate your support.
Thank you again for joining us for this educational activity. To claim credit, be sure and complete the post-test and the evaluation. Thank you again for your participation.